Hi, I'm Ralph Preston, and every Tuesday we have these Stroke Buddies Recovery and Science Zoom meetings where we try and bring you some useful information for your recovery because as a stroke survivor, as you know, it's all about the recovery. And I believe a focused approach is more effective than a non-focused approach. And how do you take a more focused approach? With knowledge. And so we're here to gain some knowledge, learn a few things about Ipsy Hand today, and we have a couple of occupational therapists with us, Emily Morgan and Lauren Sheehan. I want to welcome both of them and thank them both for taking time out of their busy schedule. And it's not about me talking, so let me turn it over to them. So welcome, ladies. And, you know, I don't usually start off with a question, but um, I'll get you to tell us a little bit about yourselves in just a sec. Or we could do that. And then the question is, it came up in the groups. People were saying, you know, I went and I had an assessment and I wish I'd known what the qualifications were beforehand because I could have eliminated myself. So maybe at some point here, we can make it clear what you need to have a certain level of upper hand function um, in order to qualify. So maybe we can make it clear what you need to qualify. That would work well for both sides of the equation because you guys don't want to do any evaluations that aren't necessary. So if people could eliminate themselves, that would be good for both sides. And now I went and talked a bunch more. So why don't you guys give us or ladies, give us a brief just overview of who you are and what you do, and we'll take it from there.
Yeah, most certainly. Thank you so much, Ralph. Thank you, community, for inviting Lauren and I. Really excited to spend some time with you today. I'm Emily Morgan. I am an occupational therapist living in Michigan. I have 20 years of experience in stroke rehabilitation practice, and I've been with Can Do Neurolutions for the last 3.5 years. I serve as clinical relations manager. So, what I do is I partner with stroke survivors, their families, their doctors, their rehab team. I do device trials, screens, training, and education. And I'll have Lauren introduce herself now.
Hi, everyone. Thank you, Ralph. Thanks for having us. I'm really excited to be here and share some more, answer your questions about Ipsy Hand and stroke recovery. So I'm Lauren Shehan, occupational therapist as well. I was previously with Neurolutions, then moved over to Can Do Health, which perhaps, Ralph, we can talk about another time. We at Can Do previously were doing and still are stroke navigation support and services after hospital discharge. And then Can Do and Neurolutions merged a couple of months ago. So all told, I think I've been with the organization for over 6 years, supporting stroke survivors both through navigation services and Ipsy Hand device support. So super excited to get a chance to talk more today.
Awesome.
Great.
Thank you. Yeah, so today I know everyone received an email introducing a little bit about Ipsy Hand, and it does sound like some of you have already looked into it, but we are going to explore what is an exciting breakthrough in stroke recovery called Ipsy Hand. It is a wearable device that's designed to help improve arm and hand movement after stroke in a completely new way. So we will walk you through how it works shortly, but for now, we just want you to think of it as a safe doctor-prescribed technology that connects your brain to your arm and your hand to help retrain movement and reinforce pathways in your brain. And it's right from the comfort of your own home. All right. So Lauren, I think you were going to speak about a few formalities of who we represent.
Yes. So Emily and I both work for Can Do Inc., which is this combination of Neurolutions and Can Do Health. Our technology, the Ipsy Hand, is manufactured by Neurolutions, a Can Do Inc. company. And Can Do, as I mentioned, has kind of two arms. We deliver multidisciplinary stroke recovery support solutions that provide support to survivors after hospital discharge, supporting the continuity of care and long-term outcomes. And by combining the FDA-cleared Ipsy Hand device with personalized telehealth services, Can Do can help bridge the gap between inpatient care and ongoing recovery needs. And so we're excited to bring these two services together, really to support patient progress after discharge and long-term stroke recovery.
Awesome. Thank you. So this presentation is educational. It is non-promotional in nature. Our goal is to really share the clinical science with everyone here who might benefit, of course, and just helping you understand how you can make informed decisions about your care. So you will learn what the technology is, how it works, the clinical science behind it. We'll explain who can benefit, things to consider before you do a consultation, just to understand if you would be included in this from the start. And we will share some videos, and I have the technology right next to me so you can see what it's like to use it in your own home. We'll take questions, of course, and then if anyone is interested in next steps, we'll give you a little bit of information to get started, but of course, the decision is always yours. And so just to kind of recap all this, I think we all can agree, Lauren and I are very passionate as our company. It's a really exciting time to be a part of stroke recovery innovations. These innovations are being researched every day. The intention behind it is to figure out what are new options out there for healing. So I think this is especially important for a community like yours, as I know that you are all focused on improving care and quality of life for yourself and other stroke survivors. Okay, so as many of you know, stroke does affect everyone differently, right? But ongoing difficulty with hand or arm movement is incredibly common. In fact, 2/3 of stroke survivors do continue to face challenges even 6 months or more after their stroke. And we also know that motor recovery often slows down, unfortunately, after the first few months. But for a long time, people were told that whatever function returns by 3 or 6 months is probably as much as they can expect. But here's the exciting part. So this belief is starting to shift. Yay. So scientists and clinicians and innovators, we're all working together to challenge those old assumptions, right? We're learning that the brain is still capable of change, right? It can still respond, it can still adapt, even well beyond the early months. So that's really what we want to share with you today. There's new ideas, there's new tools, new approaches, and a new way of thinking about what's possible in stroke recovery. So this brings us to Ipsy Hand. And thank you everyone for attending today. I just wanted to share gratitude with you, just that you took the time out of your day to learn about this. So Ipsy Hand, it's a wearable device that's used in the home, and it helps retrain your brain after stroke. It's the first and only FDA-cleared therapy of its kind. And it's designed to support arm and hand recovery, like we said earlier, in a completely new way. So this breakthrough really opens doors to progress, especially for those who have plateaued. Maybe you've tried so many options before and you're just not getting the results you hope for. And just a quick note, it might be covered by insurance with a prescription from your doctor, or if you are eligible for veteran benefits, it might be funded. All right. So Lauren.
We're wanting to share just a little bit of background as to where Ipsy Hand started. So you'll see some early prototypes and some information here, how the information or how the idea for Ipsy Hand came about, some more about the science behind it and the passion of the team to get this device into the hands of stroke survivors like you. So you'll hear a little bit about patient story as well. And there have been some changes to the device since this was filmed. So you won't be seeing sort of today's version, which we will show you shortly, but wanted to give you a little background on where the device and the idea for the device came from. Can everyone hear?
When we first started this company, people almost kind of took this as just kind of almost crazy science fiction. And I think we're getting past the believability factor. We're starting to see what was originally kind of research technology take flight in the clinical domain. And I think we're going to see many, many more of these type of technologies.
Here in St. Louis, a company called Neurolutions recently got one of the first FDA approvals ever for a BCI. In this case, a non-invasive EEG headset that reads the electrical activity of the brain. The measurements aren't as precise as with an invasive system like the one BrainGate uses, but they work for Neurolution's purpose, helping stroke victims to reconnect their mind with a paralyzed limb.
All right, so we're just going to test the headset real quick. All connections good, nice and relaxed.
My name is Mark Forrest. I live in St. Louis all my life, and turns out I had a stroke. And I was pretty much paralyzed on my right side. A lot of people told me after 6 months that I was pretty much done and I was going to have hardly any movement.
When somebody has a stroke, a part of their brain dies. For instance, the right side is injured and the left side can't move. Now, but if you talk to these patients, they can imagine moving, they can try to move, they just can't actually execute that movement.
We know that 90% of those motor fibers that control opening and closing that hand are on that side where the injury occurred. What we found is that there's actually 10% on the healthy side, on the other side of the brain, that controls thought of, I want to move my hand.
And so what we did is we created a brain-computer interface that really has 3 parts to it: a wearable headset, a robotic exoskeleton, and a tablet that walks them through how to use the system.
All right, let's see. So let's do 30 seconds rest, and then I'm going to hit next, and we'll see what control you'll get.
At the beginning of the program, it tells you not to move your hand, but think about moving your hand. And that's what you have to do.
Just imagine.
It's picking up that intention to move on the uninjured side of the brain. It's converting that intention to a movement of the exoskeleton. As the person continues to use it over time, it's essentially leading to a rewiring of the brain. There's this kind of neuroscience notion of what fires together, wires together. So when they're generating those brain signals to move and they're getting that feedback from that wearable, that's leading to new connections forming in the brain that allows eventually that uninjured side of the brain to take over control of the paralyzed limb.
My movement was just this. That's all I could do. Look how much difference I've made, progressed using that machine. I have arm movement. I have finger movement. I have wrist movement. It got me motivated for, I actually built my own fishing boat. My oldest son said it's going to sink, it's not going to float. My best friend told me it was going to sink and not going to float. Well, I proved them all wrong. Laura works in mysterious ways. Shit happens and nothing new about it. So you just make it work.
Hey.
Okay. And Ralph, we'll make sure to send you all of the links and things so that your community and the folks that are viewing today can also rewatch these if they'd like in the future. So we want to break down a little bit of what you saw in the video. Ipsy Hand, again, is a non-invasive, thought-controlled brain-computer interface that uses the signal from the brain, typically from the undamaged side of the brain, which is why it's called Ipsy Hand, or it comes from ipsilateral, to help stroke survivors improve upper limb function, and again, from the comfort of your own home. At the core, so there are 3 pieces to the device: the EEG headset, the robotic hand piece, and the tablet. At its core, the Ipsy Hand is a brain-computer interface, and we say non-invasive because it sits on the top of your head and it reads those signals just from where it sits on your scalp. And while that sounds complex, it is actually pretty simple. It allows your brain, when you're thinking about movement or that intent to move, it allows those signals to be sent to the robotic handpiece. And like they were saying in the video, with repetition, thinking about movement and then seeing and feeling your hand move on that affected side, that helps to rewire or reinforce that signal, that pattern, to help the healthy part of the brain sort of take over control of the damaged part of the brain from the stroke. So hopefully that makes sense in terms of the science. Again, the headpiece is, or the headset is just worn during therapy, and that allows those signals to be sent and reinforce that movement. The tablet guides the therapy, so it gives prompts, it gives visual cues, and goes cycles between telling the user to think about moving on that right side or left side, whichever is the impaired side, and then relaxing. So also being able to shut off those signals. And when it's used as intended, which is typically 5 days a week, an hour a day is the recommended dosage based on our research, the system can help patients progressively regain movement and function over time. And again, as Dr. Luthart, who was in the video, said, what fires together wires together. And that's really the scientific principle that the device, the Ipsy Hand, is based on.
Thank you, Lauren. So Ipsy Hand is designed for adults 18 and up who are at least 6 months post-stroke and have weakness in their arm and hand, and of course are motivated to continue their recovery journey. So the period of chronic stroke, 6 months and beyond, that's when traditional therapy oftentimes tends to slow down, but the brain still has potential to rewire and improve. Now, Ralph, you were mentioning earlier, there's people in your community who have gone to the website and we're just trying to understand, am I the right fit? So once you understand if you've had a stroke at least 6 months ago, as long as you're an adult 18 and up, when it comes to the arm and hand weakness, the really neat thing about this is you don't have to have a prerequisite of even having movement at all. In fact, people who use this device, because it is just thought controlled, do not have to have even a reflex to operate this. It's all done through thought alone. It's brain activated. But what we do want to make sure we check is that the individuals don't have severe spasticity in their hand, very tight muscles, where the hand, the wrist, and the elbow become so rigid or even contractured that the joints are fixed in place. They wouldn't be a good candidate because the device itself simply can't assist the limb physically if the limb cannot move. So what we're really looking for is someone who has the ability to just through a slow guided passive stretch, be able to get neutral in the wrist and extend their fingers to about neutral as well. And that will enable them to have a comfortable fit in the handpiece. Now, the other thing to consider, there might be people in this community who have had a craniotomy, a brain surgery, okay? If you have had that, we would just need to understand the shape of your skull. Because the sensors actually sit and rest on top of the head, it relies on picking up the brain signals through the skull. So if there's an indentation that just happens to rest right under the sensor, that potentially could cause not a safety issue, but just the inability to pick up on the connection effectively. But we always do a check on everyone before they begin their journey with Ipsy Hand by doing a signal test using the headset to make sure that we can pick up on a clear signal. So our team is going to perform a very careful screening to make sure that Ipsy Hand is a good fit for you. We want to make sure that it's safe, and we want to make sure it's going to be effective and worthwhile for anyone who does want to use it in their home. And we always do share that it is important to discuss this option with your healthcare provider to help them understand a little bit more about that technology. We'll be sharing some resources with the community that you can also share with your doctor. But our team and your doctor will work together to ensure that it's a good fit before you take the next step. And we can certainly discuss more about this in the Q&A. So before starting Ipsy Hand therapy, we do a quick non-invasive EEG signal test, and it involves just our headset and then our tablet with the loaded software. So this signal test really just helps us check that your brain's signals will work with the device. So think of it like a compatibility check. We want to make sure that your brain's natural activity can communicate effectively with Ipsy Hand for you to benefit. And it also allows us to personalize your therapy settings so the device responds best to how your brain sends the signals. So this way, the therapy really is tailored to you, and that increases the chances of making meaningful progress. Just as a quick note, most individuals will complete this test remotely. We actually use a small screening kit that we send direct to your home, and then getting on a video call, we guide you and your family all through it. And then depending on where you live, in-person screening is also an option. Now let's talk about the clinical science. That's what we're certainly all here for. Does it work? So our clinical trials did show that 7 out of 10 people by 3 months' time of using Ipsy Hand as intended improved their arm and hand movement to a meaningful degree. So on average, participants gained 8.1 points on the Fugl-Meyer assessment. I'm not sure who's familiar with the upper extremity Fugl-Meyer, but this is a gold standard test for stroke motor recovery. Now, just as a quick note as well, this level of improvement is considered statistically significant, but it's also clinically meaningful, right? So it does reflect that these individuals made real noticeable progress in their function from their baseline. So tying it all together, what could this mean for you? It does depend where you start from. So many stroke survivors with more severe impairments, even small gains, right, can translate into greater independence with daily tasks like dressing and eating. Even just having a little bit more ability to open your fingers, to hold on to your pants, to pull them up, I mean, that's a win, right? And then there's others who have more mild challenges, maybe just dexterity issues, right? Having difficulty picking up a pen, maybe coordinating their handwriting. So it could mean for those individuals being able to pick something up without dropping it as often, having a stronger grip, and even just having a smoother movement so that when you're reaching for the refrigerator door, you're able to more timely open those fingers, grab it, and pull it so your brain doesn't have to work as hard. So all in all, really, Ipsy Hand is a reminder that recovery does start in the brain. So it's a brain-activated therapy. I do want everyone to remember that. It puts the brain to work, right? It helps to rewire, strengthen the connections that support movement. But once the movement begins to return, it's important what you do with your hand, right? So that's where the principle of use it or lose it comes in. So if new movement is not used consistently, the brain can begin to let go of those gains. So we want you to make sure that as these movement patterns are starting to get reinforced, you're doing better, make sure to use it and engage your hand in your daily life. And that's an important message that our support team provides all our users. It builds on progress through consistent use, practices promoting neural recovery and brain plasticity. So think of it as well that it also could open the window for you to be able to do things that were not possible before. We have users who actually start therapy again. They were deemed by their therapist of having plateaued, but now that they're able to do something that they couldn't do before, this opens the doors to start that prescription again. And then the therapist can start to layer on other approaches that involve strengthening muscle tone and conditioning, and of course, engaging that hand and arm into daily activities.
Okay. What do results look like? So we always like to show some before and after, just so that you can get a sense of the types of improvements that Ipsy Hand has helped support for our users. This is Carmen. And she had stopped, as Emily had mentioned, kind of formal therapy, so wasn't receiving outpatient therapy any longer, but started to use the Ipsy Hand. At baseline there, you can see that she's able to slightly open her hand. She has some ability to kind of turn her palm down. But as she continues to progress, so at 12 weeks, some additional hand function, you can see her hand is more open. Those fingers are straighter. And then at 14 months, she's pretty excited about her progress with the ability to really raise that arm, reach to different heights, and as you can imagine, probably do more in her daily life, reach from shelves, involve that hand and arm in more daily activities. So we know that progress like this can be very meaningful and useful functionally in those everyday lives and the things that bring you joy and that you want to be able to get back to. So just wanted to give this background. The clinically meaningful, clinically important difference for the Fugelmeyer, which is this assessment that Emily had mentioned, is slightly above 5 points. So her progress here is really clinically significant. Of course, not everyone has this type of response. We do see a variety of different response types, and that's what Emily had mentioned as well. It really depends on where you're starting from. But that progress can be, from a small change to a larger change like Carmen experienced here. And sometimes, and really, we don't know. We're continuing to try to learn more about what makes someone really responsive to this therapy. So the team continues to do studies and look at the evidence and the outcomes to see if we can, at some point, maybe predict some of these outcomes based on where someone's starting or what their presentation is. Unfortunately, we don't know yet. We can't predict what someone's outcome will be, but maybe sometime in the future. This is a gentleman that I had the pleasure of working with on clinical trials, and Robert was over 10 years post-stroke when he started using the Ipsy Hand. Just a short video, but gives you a sense for the kinds of things that he was able to start doing after his Ipsy Hand therapy.
Doing more things with my right hand. That's what every stroke survivor wants to do. You just want to be normal again. As normal could be, just want to, participate fully in life. I can see a difference in my hand. I have a little more outside movement on my first digit, eating, holding a fork with my right hand. The progress I've made is been phenomenal for me, and it's getting me more and more enthused to keep using the device every day.
So I'm just going to tell you a little bit right now for those that might be interested in how to get started. There is a pathway that we can guide you through. So without any pressure or commitment, if you would like to use the URL at the bottom, www.neurolutions.com/stroke buddies stroke dash buddies slash you can visit our website and you'll have the opportunity to just answer a few brief questions to see if you'd be a candidate for Ipsy Hand. And if you're a regular to this group, we will absolutely pass along this link to you after the presentation.
And
Yeah, in the middle of the wall.
I'll also say that I'll put the link in the description of the video.
Awesome. Thank you, Ro.
I don't know
So
where that
once
other
you
audio is.
complete the initial questions, you'll be able to choose a time for a phone consultation. And we have specialists that know Ipsy Hand very well that will provide education on it, speak with any of the family that might be in the room who will be supporting you potentially one day with a device at home. And that specialist will just get you started to figure out if it is the right fit for you, given your presentation. If you are interested in moving forward, because this is a prescription medical device that we want your insurance to cover, your physician will need to complete our prescription template. So they can either fax or they can email it to our team, but we will provide a prescriber packet to you. That gives your physician detailed information about the device and clearly outlines the steps to get you started. So once we receive everything we need in step 2, our team will schedule what's called an Ipsy Hand qualification screening. So this includes a review of your medical history, therapy goals, and a more deeper dive clinical screening. So during this visit, you will also complete the EEG signal test. And just as a quick reminder from earlier in the presentation, this signal test is painless. It's actually a very quiet test, and it's typically done in your own home.
Interesting approach.
And that helps for brain signals to ensure that they're compatible with Ipsy Hand, and then it helps tailor the device software to your unique brain activity. So essentially, we use that information so that we can prepare it in our manufacturing lab, and then it's ready for you when it's time for delivery. So if you are a good candidate to move forward, our team will continue to support you through your recovery journey. We'll begin, of course, with comprehensive training of how to use the Ipsy Hand in your own home. And if you have family members or care partners who support you on the day-to-day, we do welcome them to be a part of the training. We do have a very responsive customer support team that's available to assist with any clinical related questions, technical questions too. We also provide something that's very unique for a medical device company. We do periodic personalized check-ins to hear about your progress. And then we might be offering tailored strategies to help you succeed with Ipsy Hand and your customized program. We're really at the time where we can discuss and take Q&A. And certainly, as the questions come up, very often folks are curious about the device itself. And so I have it right here, so I'll be able to show you the ins and outs. But I'm going to stop screen sharing so potentially I can be a little bit more full on the screen.
Thank you for that.
Yeah.
I did it last week. I automatically did it myself, and the presenter had one more thing to do. So I'm glad you did it because it's more intimate this way. I could have a million questions, but I had an aha moment during the Blumberg video. I realized Ipsy, as an ipsilateral. I can't believe that I didn't make that connection because I'm the guy that fooled around. Is Dr. Hetsler still here? Yes, he is. Dr. Hetsler is a neuroscientist, and he's the first one that made me aware of the fact. I think there's debate between 10 and 15% of the signals are on the same side. When I did that, I'm a noodler. I fool around with everything. And I started trying to see if I could, how could I use ipsilateral therapy in recovery? How could I come up with some simple exercises and things? So it may already be done, and I'd love to talk to you guys about that, but I'm also the guy that invented bilateral therapy on my bed, learning how to roll my fingers again in both directions. And I went into my OT and said, yeah, I can believe this. You can use one side of your brain to help the other. And she looked at me and said, look up mirror therapy, or not mirror box, but mirror therapy or bilateral therapy. I also got my hand back by doing mental imagery and mental practice. So this whole concept really fits into the way that I recovered and the way that I discovered and now believe that people recovered. Actually, I have a video, I'll send it to you guys, called 3 Potatoes. So I was thinking about ipsilateral, and I was making potato salad, and I grabbed 3 potatoes at once with my unaffected hand. And I said, what happens with my affected hand? And I went down and grabbed them, and took about 10 seconds. So then I went and grabbed them a couple of times with my unaffected hand. And I guess between the patterning, the visual, the brain stuff, all of a sudden I went, it wasn't like quite, bam, like just picking them up. I went, bam, like about that fast, rather than having to take me 5 seconds. So anyway, I find that really interesting that there's a whole tie into ipsilateral therapy, mental imagery, mental practice. If you
Yeah. I'll expand upon that. And you absolutely hit the nail on the head. I'm hearing you provide approaches, mental imagery, mental practice, mirror therapy, engaging those mirror neurons. These are all wonderful tools for the brain that are motor priming in nature. It's all derived from our own thought control. And that truly is what this is all about, the meat and potatoes, is how can we engage the brain to do its own healing through the power of the mind? And so we had, in the research that was done back in 2007 at WashU with Dr. Luthart and his team, they had this aha moment as well. And originally, brain-computer interface was thought to maybe just be intended for individuals that have had a spinal cord injury, where they had a healthy brain, but there were peripheral nerve pathway damage. But the aha moment began, and really the question started to come up is, I wonder if we could use this in a brain that has been damaged, that has been broken, right? And so that's where, the science started going from one question to another. Could this be used in someone that has had damage? And of course, stroke, as you know, affects so many people on this planet. It's a big deal. So stroke seemed to be a great place to start, to see if brain-computer interface could be used for stroke survivors to help them heal themselves. And so through brain mapping studies, that aha moment, that very exciting moment, was when they learned, oh my goodness, well, this makes sense. The stroke affected a hemisphere of their brain. There's pathway damage, communication lines are broken, but oh my goodness, that ipsilateral side, that undamaged hemisphere, still has the ability, although not strong, still has the ability to communicate. So could we leverage that and have someone build on those pathways, reinforce those signals through Hebbian learning. And so it became a very exciting moment to start this whole initiative, which led us to our 3 clinical trials, right? We're in a 4th clinical trial now, funded by the NIH, that will start to pull so much more data that we didn't even know from the first 3 clinical trials. We're unlocking the brain through thought. And it's just so exciting to see where this is going to go.
A little later in your presentation, I was happy to hear you say that a couple things, 3 things. The follow-up with the device involving caregivers, I think that's a good thing. But the thing I really wanted to say was functional therapy is just a big deal. I use it a lot in my recovery. I did a variation of constraint-induced movement therapy, which is, Dr. Taub's, put an oven mitt on your unaffected hand thing. I didn't want to wear an oven mitt. I didn't want my hand tied behind my back. But I through my brain, I forced myself to use that unaffected hand all the time in daily tasks, and it really worked out well for me, and I'm a big believer in functional therapy. I went so far as to carry the pitcher up to the refrigerator, put it in my unaffected hand while I open the refrigerator, put it back in my affected hand to put it in the refrigerator and try and learn how to do it without, I don't have to shake. When it was heavy, I'd put it in there, it'd shake like crazy. I finally got over that. Then take it out, close the refrigerator. Same with taking vitamins down. I had an aha moment. One day after PT, they had me take those little cones that they have you stack up, and they make courses for you to walk through out of. They had me take them off the top shelf. Well, that night I was taking the vitamins off the top shelf. I said, they almost look like cones, same thing. So I started taking them down and putting them back up 4 or 5 times just to, when I took out the vitamins. So I'm a big believer in functional therapy, and I think it's great that you guys promote some of these other concepts around how your device works, because if you do, and people listen to you and do that, they're going to have better success in their recovery and better success with your device and a better chance of ending up in one of your videos.
Ralph, I just wanted to mention something real quick, Emily, because I don't think we talked about it in the presentation. After someone receives an Ipsy Hand device, they are not on their own to use it, which I also think is really what sets us apart. There's a clinical service and a clinical team that supports Ipsy Hand users every 4 weeks on a regular basis, checking in on progress, seeing how usage is going, working on strategies if things are not working, seeing what else we can do to translate to other areas of life, right? Practice those functional tasks. So I think that's really, really important too. I think a lot of devices and a lot of companies are out there with products that can work, but it's really difficult when survivors are on their own to use them. And so I'm just really proud of the work that we're able to do to continue to support people long term with the device use. So just wanted to mention that.
Cool. You keep making me think of things. Anybody who's got a question, feel free to jump in. If you don't, I'm just going to keep the conversation going, but I don't want to monopolize it or cut anybody out. What you were just saying, Lauren, made me think about user feedback, because user feedback is, we tell people, you can't watch your hair go gray. You brush your teeth every night, you get up in the morning and, comb your hair. And so you see yourself all the time. So we tell people, keep a journal, take pictures, take videos, because you're not aware of the progress you're making because you can't watch your hair go gray. So I was curious what kind, since it's a computer interface and everything, I was curious what kind of user feedback you had to, because I think that user feedback is highly motivating to the patient, and staying motivated is a big problem because once again, you can't watch your hair go gray. It's slow. It's a slow process recovery. And so anything that you can, any information you can glean that you're making progress along the way is good. Boy, that took you way too long to say that, Ralph. Anyway, I'm curious what kind of user feedback you got.
Yeah, so there is, because it is, a piece of technology, we can see usage, which is really helpful. We can see the number of repetitions, which there's a particular target that we're, trying to aim for, with that dosage response that I think you've probably talked about. The number of repetitions that it takes to start to see meaningful change is quite a bit. So we're able to see that. We're able to see some accuracy stats in terms of the device, what the device is telling us, how often the user is sort of hitting that threshold to make the device open and close. And then there are some badges and other things that are built to hopefully motivate. There are certain things that people can earn by, a certain amount of time spent, a certain number of repetitions. So that badge piece, just trying to continue to encourage regular usage and build up that a little bit of gamification. I know there are folks that have given us feedback about gamification, and with this particular device, it's difficult because we can't actually add a lot of bells and whistles to the software due to the way that it operates. So because it's brain-computer interface based, we're really trying to get that intended movement and gather that signal. If there's too much happening, it actually can be a distraction, and that signal is not as sort of clean and clear as we need it to be. So those are some things to mention too, just about how the device and kind of the interface works. Anything else to add, Emily?
Sorry, can I interrupt slightly? Have you ever tried having people do like guided chess or like another board game where you tell them the moves to make, whereas they don't need to think about the strategy, and then you have the hand coordination of picking up the pieces, moving them over other pieces and retraction and all the movements of chess or checkers?
We haven't, Gary, but that is very interesting. Yeah, I think, were you going to mention something, Emily?
I was just going to say, we do appreciate all the feedback and the ideas that we do get from our users and also the healthcare professionals that are working with the users. And we have an innovations team that is taking all of this into consideration so that we can one day continue to build on a product, a service that is enhanced even from where we are right now. So keep these ideas coming. We would love to hear them. We want to partner with you because it is all about helping the community regain life, regain function.
Linda had her hand raised. One of the things that I think is overlooked in the whole stroke recovery, and this is kind of an aside, is we don't get what we need. And a lot of times we come up with ideas as stroke survivors. Like I said, I didn't invent something. I invented it for myself. But people like me who are always noodling around, like Gary, thinking about things, I think there's a whole that we have something to contribute and nobody's listening to us. It's one of the things that I want to do is kind of get us a seat at the table. Some of these things that we come up with are, should be studied and become part of the science. Anyway, Linda, did you have a question? It said you raised.
Yes, I did. I wanted to wait until you guys were done speaking before I just interjected. So my question is, when I first had my stroke 4 years ago, I started to have seizures, but they are controlled with medication. I don't have seizures as long as I take my medications. So I was wondering if Ipsy Hand, would I still be a good fit? Do you know if there's any problems for people that have seizures?
Good question.
You want to take that on, Emily?
Yeah, I'll absolutely take that question. We have not had adverse events with Ipsy Hand. So if you do have seizures, of course, it would be something to address with your doctor before you get going. If the seizures are triggered by concentration or, anything like that, it should be considered, but it's not something that would prohibit you from getting started. Not at all. It's not considered a precaution. It's not considered a contraindication. Great question.
Okay, great. Thank you.
Well, and more importantly, you wouldn't want it to trigger any seizures with anybody. So,
Certainly. And we have not
Right.
had reports
right.
of any sort of seizure, activity.
Because I was watching a special, I think it was on Netflix or Hulu, about a girl who had traumatic brain injury, and they were putting like the devices on her head, I guess trying to get her brain to respond, but she would have seizures in between. And I just wanted to know if you guys had any issues like with people with it triggering seizures.
It's a consideration, Linda, and we would just monitor, but like Emily said, not a contraindication for use of the device.
Okay.
I think we're going to see all kinds of expansion in this brain-computer interface world in the next 10 years. It's it's one of those things like cell phones and things that just explode. They come up with iPhone. Next thing you know, 5 years later, everybody on the planet's got a smartphone. I think we're going to see tremendous. This is my opinion only. I think we're going to see tremendous change in the brain-computer interface world in terms of recovery. And I think it has a lot of promise, which is why it's being explored.
Absolutely. And Linda, you did just make me think this might be a good time to introduce the components that I have with me. The headset itself can look, understandably, a little intimidating, right? But really, it was designed so that a stroke survivor with their one hand could put it on their head. And as you can see here, with just a little pat of my fingers to find each sensor to keep them flat to make that good contact, that's all it is. That's all it is. Now, people do want to know, will I feel anything going in? Will I feel tingling? Is there any sort of electrical conduction? That's a very fair question. And I do want everyone to know you won't actually feel anything except for the hardware of the device resting on your head. There is no input, right? So think of it as how a stethoscope against your chest is just listening to the beat of your heart. These little sensors are just going to pick up on different frequencies coming from your natural activity. So during the screening process, the tablet will guide you through what to think, what to imagine, and we have selected specific visual imageries and graphics that do facilitate the activity we're trying to capture. We're looking for the individual's ability to connect with their arm and their hand. We're also looking for the individual's ability to simply relax and inhibit. And all that goes into programming their device. Now, people that have certainly sort of lost touch, so to speak, with their arm and their hand, it takes some practice. And it can feel unnatural. And a lot of people are often saying, am I doing this right? Like, can you see what I'm thinking? When you're actually doing it, because we're not doing live imagery, we won't be able to see on the spot, but we can see afterwards. We do not read thought for thought verbally, right? So that's another thing to just get out of the way, is that we're not reading your verbal sentences. I think a lot of people would like not want others to know what's in their head. Understandable. But really it's motor intention. The thought about, I want to move my hand. And we're trying to facilitate Very discrete, distinctive fine motor patterns that really are engaging the brain right where we want them to.
I
Is
don't
any
think
other
you-
questions or thoughts? I'm more than happy to talk about the headset for a little bit. We can talk about the handpiece too, or any other questions.
I think it's cool that you can put it on one-handed and just, kind of orient things so it's all flat. That was smart thinking on somebody's part. I don't think you can read people's minds yet, but I could see how people would be worried, like that you could somehow transcribe their innermost thoughts. No, not yet.
No,
10
not
years from now, maybe.
And I just wanted to say my thanks again. I do need to jump off. Thank you so much for having us, Ralph. And feel free to stay on, Emily, and continue the conversation. But we just really appreciate the Stroke Buddies group and everything that you do.
It was nice to formally meet you and appreciate you taking the time out of your busy schedule.
Of
Laura.
course. Thank you all. We'll be in touch.
All
Thanks,
right.
Em.
Okay, thank you.
Thank I'm more than happy to stay on.
Okay. I could ask a million questions. I would talk about the future of, but a lot of mine would start to get off topic. Well, one thing that a couple people have asked that I'm sure you get this pretty regularly, and maybe we should have it in this recording, is are they working on legs?
Really good question. We are working on the lower extremity. It's not ready for prime time yet. It's early, so it's going to be several years, understandably, because we want to do this right with appropriate clinical trials and getting it through the FDA for clearance. I will just mention one of the unique things about Ipsy Hand is we are addressing an unmet need because there are so many stroke survivors that do get return of function with their gait to some degree, but continue to struggle with their arm and their hand. But the way our brain is certainly sort of built structurally is that the area representing the hand and arm in the brain is closer to the outer surface. So our sensors being closer to the edge are able to tap into that more clearly and easily. Now the leg a little deeper down. So there is a little bit more work to make sure that we can get a good clear signal non-invasively, but we are working on that behind the scenes and innovations.
Cool. Well, I think it's important to go through all the steps and get FDA approval and everything, because that way it's going to be available to a lot more people than, because it gets approved by Medicare and insurance companies and such. So I'm glad we got that. I figured that was going to be the answer. Yeah, we're working on it. It'll be a couple of years.
Yeah, if I could comment briefly. This is Bruce Hetsler. Yeah, in terms about the legs versus the arm and the sensors there, I mentioned before in some of the presentations that the body surface is mapped out on the primary motor cortex, which is in the back part of the frontal lobe. You've got that body map called the homunculus. Remember the little man that's mapped out there? Right. Yeah, little man's got big hands.
Big lip.
Not the big arms, but big hands, big mouth, big face. But the way the body is mapped out, the hands, the face are sort of on the side of the brain. The feet are up here down inside the longitudinal fissure here at the top of the brain. So it's going to be more difficult to record brain waves associated with initiating leg movement than hand, arm, face movements.
Emily, Dr. Hetsler is a neuroscientist who had a stroke 15 years ago, and he's given us 9 presentations. I mentioned him earlier because he was the first one who made me aware of the whole ipsilateral thing, just by basically putting it in lay language, some of the signals stay on the same side, and that got me to thinking. Well, I always get to thinking, but a lot of his presentations have got me to thinking about various things. So that's where he's coming from. He taught neuroscience for 42 years.
43.
43. Okay, I thought it was 42 or 3. I'll change it to
You're
43
close enough.
in my brain. A long, long time after his stroke. Believe it or not, they made him take an 8-hour cognitive exam to return to teaching. Did you get to do that in 2 days, or did they make you
2
do?
days, they divided it up into 2 4-hour sessions.
Still, 4 hours is a long time to be tested. The SATs were what, an hour or so? Anyway,
Something like that, yeah.
yeah. Anyway, so anybody got any questions?
But there was someone initially that asked about seizure activity. And again, I've not seen this unit, this IpsiHand and so on, but as I understand from the discussion here, it is recording a brain activity. And it's sort of like the olden days in the 1950s and 60s, where you would basically glue electrodes onto the scalp to record brain waves. Okay, they're not doing that now, but there are electrodes there that record what's going on, and it's the EEG or electroencephalogram recording brain waves that helps localize where seizures originate. So if a person was having seizures, that would interfere with the recording. But as I understand it, this thing is not going to stimulate the brain, so you're not going to trigger seizures. Although if a person had a seizure while it was on, it could interfere with the recording. Again, I've not seen this device, I don't know the software, but I'm assuming that's what's going on.
That was my understanding also, but and Emily's not in her head. It's not doing anything. It's not. Doesn't go this way. It goes this way, out. Recording only. I like the stethoscope analogy because we're all comfortable with. People go, "Oh, you want me to put that thing on my head?" I'm not so sure about that, but we're all comfortable with the doctor. That's why I went earlier. They listen several places to your heart. And that's second nature to us. So that's a good analogy, I think.
Thank you. There is a question in the chat.
Oh, okay, I didn't see it.
How does this device work to improve arm function? So I think this might be a great time to just kind of tie it all together. So the device is a therapeutic powered by technology called brain-computer interface. We have an EEG headset that goes on the head. Individual is wearing our handpiece on their affected side. The tablet resting on the table in front of them is going to assist them in the setup of how to turn it on, but also it is the tool that guides them through the therapy and what to think. When a person is given prompts that facilitate engagement of the fingers in a very fine motor type way, the handpiece will move their fingers in response, lifting them up and also lowering them down. We are engaging these two fingers. These are important, almost like tools for the brain, tools for the body. This is a functional way to move. But like Dr. Hetsler was saying, there's a representation on the brain that it's real estate, really. And there's a large amount of real estate related to the fingers, and especially the index and middle finger we've learned. So we want to get those jamming, right? We want to get those going. And when you're reinforcing these pathways over and over again through that process known as Hebbian learning, neuroscience, we'll say neurons that fire together, wire together, right? We're going to be kicking everything into high gear. So how does this improve arm function? That was the question. I want to pull in that arm function. So while it's called the Ipsy Hand, it absolutely is important to note that distally, we call it distal for the hand, proximal for the shoulder, through thought control engaging in distal activity, it could very well have this effect where the neurons, the synapses start to communicate with other areas on that map of our brain related to the wrist, the forearm, the elbow, the shoulder. So lo and behold, where we thought it might just help with hand function, when we looked at the results, folks benefited not just in the fingers, not just in the hand, but throughout the entire arm too. So the FDA did review all of our data, and they deemed us as a device that's appropriately called the Ipsy Hand Upper Extremity Rehabilitation System. That is our full name. So while we cannot pinpoint per se where you'll get the movement back, it is possible, like many of our other users, that movement will return in the arm as well. Now, this is something that does need to be done. You know, we do say 5 days a week, minimum of 3 months to see change. I think that is important to stress too, is if it's just used a couple times and not long enough, that dosage is not going to be enough. So we do want people to consider this something that, yeah, is going to have to be a little bit of discipline, but we do love the idea of agency and, of course, being able to take control of your own rehabilitation by layering on a new tool.
If I could just
Go ahead.
comment on one thing.
Yeah.
You mentioned Hebbian learning.
Mm-hmm.
That refers to Donald Hebb, a Canadian neuroscientist who first suggested, I think in the 1950s, that neurons that are active at the same time, that is, fire together, become connected. And that was later studied experimentally in laboratory animals using electrodes put in the brain to electrically stimulate pathways. But I think for people hearing it, they did not understand really what Hebbian learning was all about.
Yeah, thank you for expanding on that.
I got something to share real quick. There he is.
Oh, there he is.
Yeah, there's the homunculus. That's what you look like to your brain.
Mm-hmm.
I've never seen an anatomically correct homunculus before.
It looks just like you, Ralph.
All right, enough of that. I just thought, we were talking about it. It's an interesting thing. It's another thing I learned from you, Dr. Hetsler, the first talk you did on neuroplasticity. You mentioned it in your notes to me, and I said, tune in. Who knew what an homunculus is? Tune in to find out. So, like Emily, you've done a great service to this, community by sharing knowledge. Anybody else got any questions? Emily
I
does.
have a quick question.
Sure.
Would you be able to use a pencil after your therapy to write?
Just to make sure I understand the question, is it possible that Ipsy Hand could help you enough that you could hold a pencil and write? Is that the
Right, right.
I see. It depends on where your baseline is. Everyone is different. So we always are considerate of making firm claims because we know that everyone does have uniqueness to their situation. But I can certainly share that we have folks that have celebrated the ability to use a pencil and write better, or they maybe haven't been able to write at all, and they started writing again, and then they're starting to build upon that. So it's certainly possible. For those who have more severe impairments where they're not at the point of any sort of fine motor yet, they might not even be able to move much at all, right? More limitations. They would understandably have a longer way to go. So I would think that there's a number of factors that play in with using it, layering on other therapy approaches to help them with strength, coordination. So it's not a perfect one size fits all, but we always want people to just go back to your goals and what you want to do, because that can, so, it can help you no matter what. If you keep focused and keep disciplined and don't settle, use the arm, all these things play into the recovery mindset.
Okay, I got one more, and then we'll let you go. Earlier, I was going to ask you about, the exercises, the routines that you have people do with it. If you did anything like with games or anything to help encourage engagement. People have found, studies have found that when patients find what they're doing interesting and get more involved, they end up doing more of it and time passes more quickly. So that's one half of the question. The other would be, so the first half would be, what do you do to keep people engaged? And the second half would be, suppose you wanted to work on writing, can you introduce your own activities, or are all the activities sort of pre-programmed for you? Like, Winnie's question made me think about that. Could I do the regular deal for my 30 minutes and then do 10 minutes on working on my handwriting, because that's important to me?
Yeah. I'll actually answer the second half of your question first, just because that's more fresh in my brain. So anything that you want to do that's functional based and personalized would have to be done independently aside from the therapy session itself. So we would certainly encourage and celebrate after you're done with the Ipsy Hand. And in theory, I mean, you're primed. You're ready to go, right? Brain is online. That could be a very ideal time to start some of the other functional task practice exercises because of that, right? But it is not built into the actual system itself. So the program, we do have some personalizations to it, but it's not at that level yet where it is sophisticated, where you can pick functional activities and it builds in sort of an artificial intelligence type practice to guide you. But now you're giving me an idea. So I love that. I love that.
I'm full of them.
Yeah.
Gary is too. So,
Hey, Ralph, if I could mention one thing that might interest you, it does not directly relate to the Ipsy hand, I don't think, but you talked about using your good hand and your bad hand at the same time to get the finger movement. Yeah, I'm going to go back to Donald Hebb and this notion of Hebbian learning and the way that was first demonstrated in laboratory animals. You put electrodes, 3 electrodes in the brain on 3 different neurons. On one neuron, if you excite it and you record from another one, the other one becomes active. If you activate the first neuron, it causes an action potential in the second one. Now, there's another neuron that's also connected to that, a second one that the first one was firing. So if you stimulate neuron 1, neuron 2 fires an action potential. If you stimulate this other third neuron, neuron 2 is excited, but not enough to fire an action potential. It's a subthreshold stimulation. Got that?
got it. I do.
If you activate the first neuron and the third neuron at the same time, repeatedly, and then stop, and activate this third neuron again by itself, then that second one does fire an action potential. It's called post-tectonic potentiation, but that's sort of like what you did with your two hands, using the good one and the bad one at the same time over and over and over again, help to activate your bad hand to get it working. It's this notion of what fires together wires together. So your good hand was helping your bad hand by activating them both at the same
Right.
time. I'll be quiet.
I'll be a smartass for 10 seconds. My affected hand says, I didn't do anything wrong, so I can't be bad.
Okay.
Well, I'm a big believer. Actually, you need to make a note to contact Julie. I'm a big believer in I won't use the V word. I tend to say survivors rather than victims. I think if you call it a bad hand, you say I'm a victim and everything. There's, it's not quite self-fulfilling prophecy, but the script that we run in our heads has an effect on our outlook in life. So I think it's important to use good. So I'm just being a smart. When I see people do that, I go, "What do you mean bad? It didn't do anything wrong. Just was part of a stroke." One thing I thought about in all that was carryover, which is, really important thing in all this. But obviously in that, clinical trial, 12 weeks, 14 months thing, I mean, she was still doing a little bit of scarecrowing and leaning, but she clearly there was no device on her arm. She clearly had some level of carryover, which is the object of any kind of therapy, because you don't want to have to walk around with the device on your hand all the time to do anything. So making those connections are good. And that was real interesting about 1, 2, and 3. I'll have to look that up. Learn more. I'm always trying to learn more. Well, make videos about it. Actually, they've got a PT that wants me to work with them. Dr. Monahan, we had him 3 weeks ago, and he and I have the same philosophy of getting better at home and everything, and he likes my videos. So I wrote to him and said, why don't we work on videos together with your concepts, and I'll enact them as a stroke survivor. Oh, by the way, 110 people have had strokes since we started this meeting, one every 40 seconds. And one more thing, I tell people 100,000 reps instead of 10,000. 10,000 scares them, but I figure if they hear 10,000, they're going to do 1,000. If they hear 100,000, maybe they'll do 10,000. I don't know if it's working or not, but that's what I do. So enough about me. Anybody else got a question so we can let this kind lady go if there aren't any more?
There was a question in the comments that I thought would be great for me to just mention verbally the question and provide a response to it. But the question was, will this work on a hemorrhagic stroke? Or is this going to be considered an exclusion if I've had a hemorrhagic stroke? And we welcome anyone with ischemic or hemorrhagic strokes to look into Ipsy Hand. No exclusions for that.
Thank you for asking that, Linda, and thank you, Emily, for noticing in the chat. I sometimes do a good job with the chat. Sometimes I don't. Got a lot going on over here, checking things and such. So, yeah.
Wait a minute, Emily, does it take longer if you have a hemorrhagic versus an ischemic?
No, we don't have any supportive evidence that says that one type will be different in the recovery timeline for you.
Okay.
Off the top of my head, I would think it had more to do with severity and location. Severity first, location second, and type of stroke third. But I'm taking a scientific wild ass guess.
Yeah, definitely. And we are looking at the actual users that are doing Ipsy Hand with their consent and participation. And we are trying to understand, as Lauren was saying earlier, patterns and trends, stratifying their different types so that we can help guide people when it comes to understanding what will this look like for me? What can I expect? We want to be transparent and evident as much as possible. And that is something that is just really great about Can Do, who we work with. So we want people to be fully informed.
All righty. Well, one more time for everybody out there in YouTube land, the links to contact Emily, Can Do, take the next step, the link they put that she showed in her presentation, all that will be in the description underneath this video. I make them all clickable because I found you have to make things easy for people or they don't tend to do them. So I make everything easy. And Emily and Lauren out there, wherever you are, thank you, thank you, thank you. We really appreciate it. And yeah, one of the reasons we do this is for the YouTube. You know, we can get 15, 20, 30 people here, but well, Dr. Hetsler has one that's got 1,900 views. Dr. Winston and his chironeurolysis has pushing 500 in about a month. So this has some longevity. I hate the word evergreen because nothing's ever green forever, but you know, so part of the reason we do this is for people in the future. Had 4 or 5 people say, I've got PT today, I'll watch it later. They know I record them. So anyway, with that, I'll close and thank you and Lauren again. And it was a great presentation and thanks for sharing it with the community.
Thank you for the platform. Very grateful.
No problem. We'll get it out to as many people as we possibly can.